Hello, welcome to PCR Webinar, How Should I Optimize Treatment of Left Main Disease Using Intracoronary Guidance. My name is Goran Stankovic, interventional cardiologist from Belgrade, Serbia, and it's really pleasure and privilege to discuss this highly interesting topic with two great doctors, great friends, Professor Javier Escanet and Professor Tom Johnson. Javier, thank you very much for accepting to share your knowledge, experience, and practice. And I would like to start by saying that the objectives of today, next slide please, the objectives of today's webinar are the following. We will discuss and try to understand how to perform and use intracoronary physiology measurements in left main disease, then learn when and how to use imaging, IVUS and OCT for left main stenting guidance, and we'll discuss the role of imaging in different optimization techniques. To start, I will invite Professor Javier Escanet to open his presentation on physiology. Javier, please.
Thank you, Goran. It's great to be with you and with all the colleagues attending this session, and also, of course, with Tom Johnson. So the topic that we are going to discuss is the use of physiology in left main stenosis, and the most obvious question is, why do we have to use physiology in this particular subset? Well, if you have certainly a lot of challenges in assessing functional relevance of an stenosis in any stenosis in the coronary tree, when it happens in the in the left main location, you have added problems. In many occasions, you have a spillover of contrast that avoid seeing properly the ostium of the left main coronary artery. You may have problems of being orthogonal to the bifurcation, and you have, of course, the possibility of having diffuse disease in the LAD or the circumflex coronary artery. We're going to address all these challenges that are posed by angiographic assessment of stenosis severity. The fact is that when you look to series that have compared the actual functional relevance of stenosis in the left main with those that were the perception of the observers that were grading if the stenosis was significant, not significant, or they were unsure, you can see that the variability is huge. This is a paper by Hamildos a long time ago, speaking about this ambiguity of angiographic assessment in left main stenosis. Now, the advantage of physiology is that it's simple and fast. I think that it is widely available nowadays. Most cardiac catheterization laboratories have pressure guide wires, provides a direct reflection of the impact of the left main stenosis on coronary hemodynamics. And the good news is that we have evidence now for supporting the value of both hyperemic FFR and non-hyperemic indices like IFR or RFR. I must say that the studies supporting the value of FFR are more abundant. We started having these as early as the 90s, and these were first tested using the cutoff of FFR for 0.75 for hemodynamic relevance, but we have also some studies using the cutoff of 0.80. Typically, these studies, what they have demonstrated is that deferral of revascularization in stenosis with a non-ischemic FFR value is as safe as treating stenosis that has ischemic FFR values. So basically, this is the way that we have compared so far. And I will leave it at this point, and we can, if you wish, discuss some of the aspects related to the practicality of using physiology in the left main.
Yeah. Tom, in your regular practice, how frequently you actually use physiology in decision making, and at what level or at what stage of the procedure?
So we use physiology a lot of the time. I think with regard left main and also ostial right coronary, there's a concern just about undertaking it accurately and safely. So clearly we always have to be mindful of the interaction of the guide catheter with the vessel. So there's that issue of wanting to be coaxial and aligned to get appropriate angiographic appearances. But then in terms of the physiological assessment, we have to be absolutely clear that the guide's not interacting with the disease. And so I'll often place an additional guide wire down the coronary to facilitate a stable position and also allow the backing out of the guide catheter. And so there's a very important relationship amongst the team in the cath lab about that appreciation of damping or ventricularization of the waveform. Because if we're not aware of that, then we risk actually making inappropriate measurements with physiology, despite that being the best measure of significance.
Thanks, Tom.
I think this is a very important comment, actually, if I may, Goran, because as Tom is saying, sometimes if you have an ostial stenosis, you may decide to perform equalization of pressures with your pressure wire out in the aorta, for example, for engaging. And also you will be exquisite about the waveform of your aortic pressure during the examination. You should make sure that if you are inducing hyperemia, that the increasing flow is not engaging the guiding catheter and causing damping of the aortic pressure. So I think that it is entirely true that there are a number of recommendations for left main indication. Typically, we use intravenous adenosine, not intracoronary in this location, because we find it safer from that regard, or, of course, non-hyperemic indexes.
Javier, in the same line, can you speculate and share with us data on the safety of deferring left main revascularization based on FFR-IFR?
Yeah, thank you, Goran. I think that's interesting. I'm going to show one slide, which basically reflects two studies that are very similar to each other. The first one that you are seeing here at the left is the Hamilos study that basically compared, as I mentioned before, outcome of patients in whom left main stenosis was deferred based on FFR against those who had ischemic values and therefore were treated. And you can see that the outcome in the long term is similar. And at the right, you have the defined left main study that was presented last year and has already been published. Basically follow the same design, but using IFR. Again, if left main was less than 0.89, the stenosis was treated. And the outcome of these patients was compared with those with IFR more than 0.89 and that were deferred. And as you can see, in the long term, the results are comparable.
Yeah, we received question from Cyan. If we have both FFR and IVUS data in an individual patient and FFR is in gray zone, does IVUS plaque characteristics influence your decision on intervention?
Tom, do you want to answer this one?
That's a good question. So we're going to look a little later at the role that imaging may play in terms of understanding both the significance but also the nature of the plaque. I think that's a very difficult question to answer specifically, Simon, because I think it will come down to the individual characteristics of the patient. So I think we'd have to take that looking at a specific lesion. I think the difficulty would be, why have you taken both modalities? Why have you taken the pressure wire and the IVUS? And I think what Javier has outlined is that I think where we're trying to make a decision about the significance of the lesion, then using the physiology is probably the right way. Now,
I think we should also use possibility to discuss that on Twitter and open chat on all remaining questions. You understand that there will be many questions that we will not be able to completely address, but it's very good to put those questions also on PCR Online and Twitter so we can continue discussion. What I frequently find difficult to interpret in my practice is the influence of distal disease on physiology assessment of the left main severity. And I would like to ask Javier to comment also on the impact of distal disease.
Yeah, thank you. Thank you, Goran, because that's a very important topic. Let me just show you an example, a practical example. This is a patient, it's an inferior myocardial infarction, primary PCI, and as you can probably notice, we saw that there was a stenosis in the left main. We decided to bring back the patient a few days later, and obviously it is confirmed that there is apparently very severe stenosis in the ostium of the left main, and we interrogated with a pressure guide wire. We placed actually 2 guide wires, so we did not have much interaction with the left main. Well, according to this, the left main was not significant, 0.84. But in the mid of the LAD, the stenosis, the FFR was pathological. So you can see that here we are performing a pressure pullback after treating the LAD and the diagonal. And then, interestingly, and you probably noticed this, we will see it in a second again, what we had is a clear effect of the demonstration of the interaction that you may have if you have severe disease downstream. In the next slide, you will see this again. So remember, before treating the stenosis that were located in the LAD and diagonal, the FFR at the point where the arrow locates the sensor was 0.84. After treating the distal stenosis, we had an FFR that demonstrated that this stenosis in the left main was severe, and of course it was successfully treated. So as a rule of thumb, remember, if you have a severe stenosis downstream the left main, you have to consider to what degree they may affect your measurements in the left main. And that is because typically with FFR, you have some degree of crosstalk. It is true that in situations where, for example, you have a tight stenosis in the proximal circumflex or a tight stenosis in the proximal LAD, the chances of having a crosstalk, an interaction between FFR values distal to that stenosis and distal to the left main is higher. It also happens in situations, and here you are seeing basically in this graph, the scenario C, which is the situation where you have an occlusion of the right coronary artery, and that therefore there are a lot of collaterals coming from the left coronary artery that are providing blood to this large myocardial bed. In that situation, you have to anticipate that if you open the right coronary artery, probably the degree of relevance, of functional relevance of that left main stenosis will be not that important. So you should keep this in mind. Now, there are new opportunities in assessing this, and this will be my personal advice, by performing longitudinal assessment of the whole vessel every time that you make a decision on the left main. This is a situation where the left main, was deemed significant by a colleague. She had interrogated the middle AD, found this 0.76 FFR value. But interestingly, what we did later was performing a pullback using IFR, a non-hyperemic index, which potentially has less crosstalk between proximal and distal stenosis. And when you analyze the pullback curve that you have at the right, you understand that actually most of the pressure loss is due to the mid-LAD segment and not to the left main. You can see clearly that the left main, the blue line at the level of the left main is actually showing non-ischemic IFR values. So based on this, we treated selectively first that part of the LAD, repeated the measurement using in this occasion FFR, and we could see that actually the FFR is non-significant. So
if you go back a slide just to the pullback, because I must confess we don't here in Bristol have IFR, so we are committed to using FFR as our assessment. And so I use this pullback. You've already mentioned this distinction between giving bolus doses of adenosine for a hyperemic assessment by FFR down the guide, or particularly when we're challenged with these ostial lesions, we'll use intravenous adenosine. And we, by standard of practice, use intravenous adenosine for all of our FFR assessments. But I will make a pullback of my pressure wire. I tend to change the scale of my sweep speed, so I go to 10 millimeters a second, which gives me a very equivalent tracing that you achieve there with the IFR. But I'm always conscious of the fact that there is that interaction between lesions. You mentioned about this kind of important crosstalk. So can I use my FFR pullback in the same way as you use your beautiful IFR pullback, or do I have to do something slightly different?
Well, personally, now you have a lot of availability of non-hyperemic indexes. Personally, I believe that you have less chances of crosstalk between distal stenosis and left vein stenosis if you're using a resting index. And the example I showed you before was a good example, that if you're performing a pullback with FFR, you will be fooled about the significance of the left main stenosis by the distal disease, because in a way that is what happens. Hyperemia amplifies a lot the turbulence and provides much more signal-to-noise ratio, so to speak, to the distal stenosis than the proximal one. And that is one of the beauty, and there are many publications addressing this value of non-hyperemic pressure pullbacks as better tools, perhaps, to predict the final result when you treat a specific segment of the vessel. So that would be my recommendation at this particular point.
So in which case, then, I have to be sure I'm happy to treat all lesions if I'm going to pursue intervention, so that once I've treated one and I've reassessed, I may be committed to treating the other lesion too, as you showed in that example.
In the previous one, exactly. Yeah. Well, but in this case, it was a good example that we had good evidence that before embarking in treating the vessel, we gained information about the relevance of this mid-LAD stenosis. We treated it, and actually the subsequent measurement confirmed that we had done the right thing.
Yeah.
Javier, we have a question from Carlos Uribe, our friend from Latin America. We don't have intravenous adenosine, only intracoronary adenosine. Is it safe to defer left main PCI procedure based on intracoronary adenosine assessment? And what other options do we have? Maybe IFR. So this goes in line also with your current discussion.
Yes. Hi, Carlos. So this is a very important question, of course. I think you can perfectly do it, with intracoronary injections of adenosine. The only thing you have to make sure is that there is no spillover of the adenosine in the coronary, in the Valsalva sinuses, that you are properly engaged. And the second thing is make sure that once that you have delivered the bolus of adenosine, make sure that the guiding catheter goes back, so it is not engaged into the left main. I think that would be my recommendation. But certainly, you can use it. Of course, you will not be able to make a hyperemic pullback. For that, you need intravenous adenosine.
Yeah. In addition to having indication for treatment, what about the assessment of the result of left main PCI? How can we use physiology to evaluate the result of PCI?
Yeah, that's a very timely question. Let me just see if we can move ahead with the slides. One more slide. And I'm going to show you exactly a case of what you are referring to. This is a Medina 111 left main stenosis, and this is a very good result. I'm not going to stop in saying it was provisional stenting, very good angiographic result. We were very happy. But we follow the rule of thumb of performing a pressure pullback. And this is actually with co-registration. And we found this, there was a very severe stenosis in the mid-LAD that we were leaving behind. And it's a very typical scenario that you have a very sort of severe stenosis in the left main. Your eyes go to this stenosis. Your attention gets focused on particularly treating this. And you may omit something that is ischemia generating, that is downstream the vessel. And you can see here the measurements with co-registration before and after PCI. This is the final result. There is another scenario that is important as well. That is the scenario of jailed side branches. This is a case of a stent implanted in the LAD, in the left main towards the LAD after making provisional stenting. And still, there was doubt as to this pinched circumflex and there was some considerations as to whether to embark into performing two stent technique. But when we performed a measurement with FFR, we saw clearly that this was non-flow limiting. And in some cases, what we've done actually is to leave the pressure guide wire in place, like it is right now in the slide, and then performed additional pod, for example, with a larger balloon. And sometimes you can see that you can improve the hemodynamics in the jailed side branch simply by performing a better optimization of your stent. And you can keep your wire there, your pressure guide wire, to perform the monitoring of your intervention.
Javier, just if we hold on that slide, because I think this for me does generate some interesting discussion around the use of physiology, and clearly there's beautiful data, particularly originally from South Korea, in terms of the use of pressure wire to assess the significance of your side branch. But I do wonder whether here, where we're focusing on the left main and the most important of bifurcations, whether that same rule can be played out. That I worry in this setting that leaving that ostial stenosis, although the physiology is reassuring, may be a driver for subsequent stent or not stent failure, but lesion failure, because we know from kind of beautiful shear stress studies that it's that outer wall of the circumflex ostium that may be the most likely place to fail. And so we've shifted the carina, we've had plaque shift that has resulted in some restriction to the ostium of that circ, which may in the future result in trouble. So I would be actually using the angiogram rather than the physiology at this point to guide whether I'm kissing or not. I wonder, that this was actually recently played out in a case example shown by Greg Stone on Twitter that resulted in the most incredible discussions, exactly these discussions around, do we really use physiology at this point, or should we just be optimizing by the angiogram? What do we do? And there was a clear split amongst the community. So, Goran, what would be your practice in this situation?
Yeah, I have to say that I really learned a lot, especially from the Visible Heart Lab, that optimization of the result of crossover stenting with the extensive post-dilatation, both distally and proximally, frequently have two mechanistic phenomena which may create this angiographic appearance. First one is carina shift, which creates this kind of angiographically tight stenosis. In addition, what we have with post-dilatation of the stent in the main vessel is overexpansion and overstretching. So we have oval shape deformation of the ostium of the side branch, in this case of the circumflex. This oval shape overexpansion will actually preserve the area, so physiologically negative result, like in this case 0.9 for FFR, could be found with very tight angiographic appearance of stenosis. So I really see the place for having physiology to make decision after stenting of the main vessel. This is part of the consensus document of European Bifurcation Club as well, to use physiology in case of doubt to assess functional significance of the jailed side branch. But in addition, if I can be practical, from the studies in provisional, kissing balloon inflation does not improve clinical outcome, but there is no penalty for performing final kissing. So if I have doubt and I have large vessel like left main, I would rather proceed with kissing, remove the metal, and position carina in the center with simultaneous inflation of two balloons in case of doubt.
Goran, I think an important message for the colleagues regarding this, and that's basically what I think, is that sometimes we jump from a scenario where left main decisions on left main revascularization and guidance are purely based on angiography, which is a very suboptimal tool. And then we go into very exquisite, and hypothetical scenarios. I think that these techniques gives you enormous information to use them, but they don't take out your responsibility as a physician of deciding for the specific patient what you have to do. This is something very important. before there was a colleague saying, what about if the cutoff is 0.80, is exactly in the middle, etc. Cutoffs do not matter in these particular situations. Cutoffs, cutoff of FFR 0.80 can be very important in a clinical trial. But for the sake of treating a specific patient, you have to take into consideration so many different aspects. And these techniques, imaging, physiology, will contribute enormously to make a sound decision. But at the end of the day, it will be your decision. The decision will not be made simply by the technique.
Yeah,
I think
can we address a couple of questions, Tom? I'm really sorry. Just briefly, there are multiple questions that I think deserve your answers and opinion on. So, Schach is asking, in presence of LAD stenosis, what cutoff of IFR and FFR can be used to determine significant left main stenosis?
Well, as I say, my recommendation at this particular point will be to perform a non-hyperemic pullback of the whole vessel, and provided that you don't have critical mid-LAD stenosis, for example, providing that you don't have a stenosis that at rest is flow limiting, you will be able to separate what is the effect of distal disease from left main disease. At least you will know if you have to treat first the distal disease, because otherwise, you will have a suboptimal result. I think that is probably the most relevant aspect. We need more evidence on this. We need more studies, but that is what we already do in our clinical practice. We use non-hyperemic pullbacks to decide if the problem is concentrated in the left main or if the problem is shared also with downstream stenosis.
Dr. Bakar is asking, does using workhorse coronary wire for guide stabilization affect IFR or FFR values obtained?
No. Really.
And Dr. Carlos Uribe again, what about concerning and preoccupying post-POT-induced side branch edema for FFR evaluation of post-PCI result? What is the impact of edema or microdissection of tissue at the ostium of the side branch on physiology evaluation? If you dilate the side branch and create edema and barotrauma with small dissection, does that impact the physiologic evaluation?
I think that you are probably the person to answer that, Goran, because you've done a lot of work also based on histologic, on pathology. But my impression is that, of course, this may happen. Although, again, it's something that you have to take with a pinch of salt and make a decision whenever you see that if you have a tight flow-limiting stenosis, I will certainly not leave it like that, thinking that it's probably going to improve when that the hematoma, edema, etc. resolves.
Sure. So just to sum up, if we have doubt, physiology can reliably help us determine functional physiologic significance of the jailed side branch. Am I right?
That's my impression. Yeah, I think that is really important. And again, I will emphasize that it's a very good tool also to assess the effect of optimization in the proximal part of the proximal to the jailed side branch. The effect to monitor the hemodynamic effect of POT, actually.
Yeah, but there is always possibility to go one level up using also imaging. So let's move now and shift gear to use of IVUS. I think you have some nice examples of the importance of imaging in left main PCI. If we can switch back to slides and give the next slide of Dr. Javier.
Yes, so let's first go briefly over the value of imaging to make decisions from on the functional relevance of stenosis in the left main, and then Tom will expand on how to guide your intervention. Now, IVUS, of course, is easy to perform. It's a one-stop shop method for both functional assessment of the left main stenosis and also for guidance. And it is probably the only location in the coronary artery tree where you can rely to make decisions on functional severity. There are a number of reasons for that. We are not going to discuss it, but as you can see here, there are many studies that have looked into the safety of deferral of left main stenosis revascularization based on specific minimal luminal areas of the left main. Again, following the same design like the studies with FFR, comparing with the outcome of patients in whom the stenosis was treated due to tighter stenosis according to IVUS. And these studies are reassuring. Now, this is a very important message coming from EAPCI document on the use of intracoronary imaging. Actually, Tom Johnson is the first author. Basically, from a practical perspective, the recommendation that we have now is that if your minimal luminal area measured with IVUS in the left main is less than 4 millimeters squares, or if the minimal luminal area is more than 6 millimeters squares, then you have already evidence as to whether defer or treat the stenosis in the left main. And if the minimal luminal area is between these two values, then probably you should try to fine-tune the measurements using also physiology. I like very much this approach because it's very complementary to the broader recommendation that the clinical practice guidelines on myocardial revascularization made on the use of IVUS in this scenario. I think that this is a very practical approach.
Okay, if we just pause on that slide just for a moment, because I think this leads back to the question that Cyan asked about the plaque characteristics. So the example on that right-hand panel of an MLA of more than 6.7 millimeters squared in that example, we actually see on that IVUS quite high-grade, high-burden disease. And that was kind of what Cyan, I think, was kind of alluding to, is if you had a grey zone measurement on the FFR and you had a plaque looking like that on the IVUS, do you walk away? And I think that's why this is so difficult to answer, Cyan, because there is part of me that would worry about the nature of that plaque and the risk of rupture, but it is evidence-based less. There is nothing that we could really base the decision on other than a gut feeling. And so I think the most important thing there is that you have the safety of both the imaging and the physiology to stop and involve colleagues, surgeons, your interventional colleagues, to actually discuss amongst a heart team how is best to proceed with a patient of this sort. And so those decisions can be deferred. And Javier showed beautifully at the beginning, deferral versus treatment in the setting of FFR positive, FFR negative offers very good outcome. The only other aspect I'd just mention is this difference between the 4.5 and the 6 on that table that Javier had on the previous slide. The key issue there was that we have populations from different territories globally. And so the 4.5 cutoff is very much driven by a South Asian and East Asian population who inherently have a slightly smaller left main. And so that 4.5 cutoff is to ensure that we capture patients of every shape and size, and that's where a robust cutoff can be made. But that grey zone between 4, 5, and 6, I think, reflects the differences globally amongst our populations. Sorry, I think that's just an important point to.
I think thank you very much for the remarks, Tom. And I emphasize, I like very much this graph because it provides a very nice map on the use of IVUS to make decisions in the left main on functional stenosis relevance. Something that also we have learned, of course, with the use of IVUS, and this again is from another document recently published from the EBC, is that when you look to the different type of characteristics of the left main stenosis according to the Medina classification, and you double check this with intracoronary imaging, you find that typically in 2/3 of the cases, you have plaque actually affecting the main left main, proximal LAD, and proximal circumflex. So you have, so to speak, an IVUS Medina 111 in 2/3 of the cases with left main stenosis. And this, of course, may have enormous implications for your stenting technique in achieving an optimal result from imaging perspective, etc. Again, emphasizing the importance of intracoronary imaging to get a much better picture of what is the substrate of left main disease. Finally, a glimpse into the future. I think that we will have more opportunities of having multi-line CTs in our patients. This is an ongoing trend. And if you combine this with the calculation of FFRCT, then you probably have a great tool to plan your interventions. And the reason is because first, you are completely free of the limitations of the C-arm in terms of angulations. You can have true orthogonal projections look into the anatomy of the left main, and you can see beautifully, as you can see in this slide, the distribution of flow-limiting disease in the coronary artery, understanding if that left main is the ischemic-generating problem or if it is located downstream.
Javier, can I ask you two questions which are really relevant to this part of our webinar? Dr. Emad Abdelhey is asking, what is your last update in evaluation of ostial circumflex subtotal lesion, Medina 001, in your cath lab? What is the sequence of decision-making and strategy planning?
Well, I mean, typically we rely a lot on physiology for one reason, and is that sometimes crossing with an IVUS or even with an OCT, a very tight, as it mentioned here, proximal circumflex stenosis can be difficult. So I think that obviously the first thing what I will say is physiology to understand if it is severe. And once that you know that it is severe, it is bound to be treated. You name it. I mean, if you decide that you are going to treat it, of course, you can predilate and then perform imaging, etc., etc. But I think that in that particular scenario, physiology probably is the most direct way.
Yeah, thank you very much. I remember we did together with a live case from your cath lab, very tight subtotal ostial circ. I was with Thierry Lefebvre trying to moderate discussion on the case, and this was really fantastic demonstration. I hope we can still see it at PCR online, how to use physiology and then continue with the imaging. You used IVUS to evaluate all the necessary characteristics of that plaque, dimensions, distally, proximally, and you did crossover from the left main into the circ, optimizing that result inside the left main. But everything was very sophisticated and based on precise assessment by IVUS and by FFR, and I really thank you for that demonstration. And one more question, which is also, I think, related to your presentation. Dr. Kondapalli is asking, much of the most decision-making is currently based on either physiology or imaging guidance. How close do you think we are to integrate plaque activity to decision-making?
I think that is, is something that actually we could go through the case that Tom is going to share with us, because it would be a beautiful example of understanding what is the substrate of disease and how it may influence your decision-making in left main.
Thanks, that's great. So many questions on OCT. So we open the second part and Tom Johnson will present very interesting case.
Thanks, Goran. So it's a great pleasure to be joining you, and thank you. And fantastic discussion so far. And I think increasingly we would like probably to use both physiology and imaging in these cases if we're looking for the optimal result. But clearly there are challenges in terms of cost. These are my conflicts. I want to share with you a case which is fairly recent, actually, just before Christmas, back in October. So again, importantly, within the kind of COVID era, which has some issue in terms of the decision-making, which I think has been different for the last 12 months in the way sometimes we deal with cases. But this was a young patient, 49-year-old male, presenting with no previous history, with a fairly short time frame. Pain onset at 5 o'clock in the evening, pain peaking around about 7, and presented on his own to our accident and emergency department an hour later. Now, actually, concerningly at that time, he demonstrated a lot of high-risk features. There were T-wave changes on the ECG across the anterior territory, a markedly elevated troponin, which we got back very quickly. And actually, the echocardiogram done in the ED department demonstrated, most concerningly, thrombus within the apex of the left ventricle and akinesia of those distal segments. And so we brought him directly to the cath lab. And so these are the initial angio images that we're faced with. So a dominant right coronary, which is unobstructed. In this PA caudal projection of the left, this is taken with an EBU guide catheter from the radial. We see an ambiguous lesion in the proximal LAD. So that certainly seems to show some relevance. And we see reduced flow to the apex, consistent with what we've seen on the echocardiogram. It's important to reflect that the patient at this stage has ongoing chest pain, but in the absence of ST segment elevation. And we see better in this spider projection, a moderate lesion, really at best moderate, with some haziness in the ostium to proximal LAD. And again, this slightly sluggish TIMI2 filling of the distal LAD. So I'd turn it back to Goran and Javier and the participants just to say, well, where do we go next? Obviously, it's loaded by virtue of the fact I'm going to show some imaging, but what would you do next?
Thank you, Tom. I also registered, myself for this webinar. I want to learn from both of you. So Javier, if this is your case, please, what would be the sequence of decision-making process?
Well, I mean, my suggestion before we move to see what Tom did is keep an eye in this angiographic shadowgram that is telling us nothing, basically, about what happens there in this patient who had an acute coronary syndrome. We suspect that the effect must be very extensive because it has an apical thrombus. But, apart from that, we lack any information as to the severity of the stenosis in the region of the left main, proximal LAD, and the substrate. So let's have a look to the clarifying effect of imaging.
I would expect, on ECG, I would expect valence sign in this kind of lesion in the proximal LAD.
You certainly will go for physiology here, because obviously you are in the context of an acute coronary syndrome, so you will not make decisions based on physiology because the subtended myocardial mass can be stunned by the ischemia.
I mean, Javier, that was part of the reason for showing it, so that we don't have overlap in terms of considering physiology against imaging. And I think this actually leads on a little to our second consensus document in terms of imaging, where we really emphasized the role that imaging may play in acute coronary syndrome in terms of trying to understand what's happening. Now, many might argue we've got flow, you've got only a moderate stenosis. There could be a strategy of conservative therapy, commencing antithrombotic treatment and allowing this patient to settle. Now, actually, I'm very lucky to work in a department closely with surgeons. Now, actually, this was 8 o'clock, 9 o'clock in the evening on call. I spoke with one of my surgeons who was in the building to say, this is a young guy, he's got a lesion in his LAD. You're happy for me to intervene here if we need to. I'm going to image it, understand better what's going on. He's already had an insult to his apex. He's showing highly threatening presentation. We need to do something. And I think it's important then to consider the options. I wonder, due to the fact that he's already shown akinesia, that actually he's had a stuttering event. And although his symptoms were relatively short framed, 5 to 7 o'clock in the evening in our cath lab by 9 o'clock, he's actually probably done some earlier damage, which may well go hand in hand with this being an erosive event, if we want to kind of drill down on the kind of academic element to this. But what we see by OCT is clearly a culprit lesion in the proximal LAD. We see evidence of very marked burden of thrombus. The problem there being that the thrombus attenuates the underlying tissue. So if we look at some still frames of this OCT, we see a relatively healthy 4 millimeter, 3.5, 4 millimeter vessel just downstream of the lesion. Then we see this evidence of thrombus between 9, 10, 11 o'clock on the OCT still frame, a much higher burden thrombus more proximally. And there we really then can't delineate underlying vessel. So it may be that IVUS at this point would have offered us more opportunity to understand the underlying plaque. And then most importantly, I think we see at the ostium of the LAD that there is evidence of significant disease. And there's often a debate, and the question that was just had, Goran, about a Medina 001 ostial circumflex, how would we treat? There's always a temptation to think, well, let's avoid the left main, let's nail the ostium, let's stent it just to the ostium of the vessel. And I think what Javier's slide from the EBC IVUS consensus shows is you will always be fooled, and there is always disease that extends back into the left main, or at least 2/3 of the time for sure. And so more often than not, we should be considering protection of the left main rather than risking dissection and then difficulty in managing the most important element of this lesion. So from this, I took that he has a highly thrombotic lesion. Has ongoing pain. I felt duty bound really to treat, and due to the ostial nature of the LAD disease, stent from left main to LAD using the appropriate sizing I've taken from the OCT. I mean, there could be an argument to just treat this guy aggressively with antithrombotic treatment and then see how this resolves as per the kind of erosion study. But I think the unique nature of this being ostial LAD and the territory that's subtended made me feel much more comfortable with treating this up front with a percutaneous strategy.
I think that's what you're saying is extremely important, and the fear of avoidance nailing the ostial LAD, which, as you say, is not working. The fear that you are embarking into treating or stenting up to the left main. I think it's important to remember that placing a stent into the left main is different than treating a left main stenosis, in the sense that the possibilities, the chances of generating restenosis, for example, by implanting a stent in a vessel that you are not stretching, that you are not damaging, that you are simply accommodating the stent, are much lower than stenting, inside a plaque. And I think that is something that, if you certainly overweights the limitations of trying to nail your stent to the proximal LAD, to the ostial LAD.
Yeah, no, I think that's absolutely right. Then I think there's a duty of care, though, to ensure that we do effectively oppose that stent. And here, then, we have this clear issue in terms of discrepancy of size. So I've said 3.5 in the LAD, but the left main is measuring 4.55 millimeters. So firstly, we have to select a device that has the expansile capacity. And then secondly, we have to be very mindful that having, as I show here, stented, albeit at quite high pressure, 18 atmospheres into the LAD, we're going to have a stent that is just free of the vessel wall in the left main. And so the next step could be disastrous, because aggressive engagement of the guide catheter, passing a very stiff, non-compliant balloon onto the edge of that stent could result in quite significant deformation, and then very great difficulty in then achieving a reasonable result. So absolute care at this point has to be taken. And Goran's already alluded to the visible heart material. That's one of the things that we learn very quickly from that is quite how much, risk there is in us distorting and destroying the beauty of the devices that have been engineered to perfection. So the next maneuver here is essential, which is obviously proximal optimization. So placement of a 4.5 balloon measured taken to the carina, as you've seen in that still frame on the right side, and inflated, and then brought back more proximally to ensure that we effectively oppose the stent. And at this point, then actually I take another OCT run. And I think this is really important. So we see then with that bulky thrombus that there's a degree of protrusion of the thrombus through the struts. In fact, if you just focus on the lumen profile, the brown band across the center of the image, we see that we have a minimal stent area, which is very acceptable, of over 7 millimeters squared in the LAD. But actually referenced, its expansion is only 70%, and so actually significantly less than we should be attempting to achieve. And again, this hints at the danger of using the numbers. So I think we have to focus here on trying to better optimize. We have then the value of being able to use the three-dimensional reconstruction software, which shows here beautifully the guide wire of the trapped guide wire in the circumflex. Goran's alluded to this idea that the ostium to the side branch might become slightly ovoid, and actually that red outline shows nicely the circumflex ostium we just see coming back into view here as it rotates back clockwise, and then struts that are kind of gathered across the ostium. And so at this point, as Javier said, this isn't like treating a diseased left main. This is about now trying to optimize for a long term in this 49-year-old gentleman. And so now I want to recross and to try and cover those struts, and then sequentially post-dilate the LAD stent to ensure that we get optimal expansion up certainly above 80%, if not above 90% if I can achieve it. So utilizing now, this just shows again as we tip up into the ostium of the circumflex, the gathering of the struts across the ostium. But I recross with a wire and repeat the OCT. And actually what we see here is this appears to be a relatively proximal cross. Now I think actually the interpretation of this, despite the fantastic resolution, is actually quite challenging. But it's actually made much simpler by using the software that's available, but sometimes isn't used, I think, as frequently. So going into the fly-through navigation mode and then just taking out the vessel wall, we see here again these beautiful three-dimensional reconstructions. And actually the wire appears to cross very, very proximally. It's not very well visualized. It's actually buried under the other wire, the LAD wire. But my concern here, certainly through looking through the still frames, if you look at the cross-sectional imaging of the OCT, is that this wire has crossed very proximal. And actually, if we pursued then a KISS, we might leave stent struts across the ostium. And that would bring me back to Goran's point he made earlier, which is there's no potential penalty in kissing. I would argue differently. I think in the absence of using imaging, there may well be a penalty because we don't know where the wire's crossing. And the subsequent KISS might actually result in us distorting the architecture of the stent in a way that is suboptimal. So I would always want to use imaging to then better establish that. So then we can
add, Tom, just to clarify for myself as well, with this proximal crossing, if you proceed with kissing, you are actually pushing that metal inside the left main stent and creating metallic neocarina. And this is really potential danger that we need to be aware if we don't use imaging. And I'm really trying to use this webinar to really promote the practical value of applying physiology and imaging in our everyday work.
I mean, I think I have to be slightly cautious, Goran, in that I think it's a theoretical danger. We await. October study continues to enroll using a very dedicated protocol, much like I'm demonstrating here, to see whether there is value and there is a clinical benefit in terms of optimizing that. But there would be a concern here that we leave a marked metallic neocarina, as you say. So this is a second recross, which still isn't ideal, but we see now much more clearly the second wire, but now up onto the roof of this three-dimensional reconstruction and is now crossing more distally. It may not be perfect. We've got 3 or 4 options for where this wire might cross. Javier mentioned, as we were discussing earlier, that it can be that using a dual lumen catheter can aid the passage of your wire or give you more directional control. That's not something I've done in this case example, but at this point I was accepting the cross of this wire to then undertake a kissing balloon inflation. Now, actually, having seen that clustering of struts across the ostium of the circumflex, it came as no surprise to me that actually delivery of a device was difficult. But we then had the beauty of the stent in the LAD to act as an anchor. So here we have a balloon up in the LAD, facilitating the cross of our circumflex balloon. And so these are two non-compliant balloons, 4.0 in the LAD and a 3.5 in the circumflex, mindful of the fact that this is a provisional kissing inflation, not wanting to overly traumatize the ostium of the circumflex. We heard earlier about the potential of hematoma and swelling. And then importantly, to go back and to position a repot, trying to avoid the carina that we have just fashioned. And so this is a 6 millimeter length, 5.0 diameter balloon. And again, just showing, if you don't have the imaging available, then actually a stent boost can offer you very clear evidence of where you're placing your devices. But it allowed us then to facilitate really a very nice final result. And so here we see beautifully opening of the ostium of the circumflex. And most importantly then, if we look at the optimization, I highlighted we had a perfectly reasonable MSA of 7.6. We've actually brought that up to 9.5. And so I've just finished really with this understanding of the numbers. We'll move on from this three-dimensional reconstruction in a moment, which shows beautiful opening now of that ostium. We see how much larger and more spherical the ostium of that circumflex is. But in terms of this numerical optimization, we've historically used the cutoff of 8765 coming from our South Korean colleagues. And I've already mentioned that this geographical difference in terms of vessel size. In this 49-year-old Bristolian, I've managed to get an LAD MSA of 9. And then the left main is 15. So had we used an 8 millimeter square cutoff, we'd have actually only had a 50% expansion in that very large left main. So we have to be cautious about using numerical cutoff values. And that's been beautifully kind of reinforced by the IVUS sub-study of the Noble left main study, which showed that, again, these European measures of MSA are very distinct from other areas of the world. And here we saw in the Noble left main cohort that if an MSA was above 13 millimeters squared out to 5 years, there was no target lesion revascularization. So I'd be very hopeful that with this 15 millimeter squared left main, albeit an undiseased left main that I've simply stented to secure the LAD, that we offer this patient really a very good long-term result. But that couldn't have been achieved, I don't think, without using the imaging kind of in a stepwise approach. I hope that's
just
useful.
One question, Tom, for you, because now we are almost at the end. Dr. Bakar is asking, fantastic result. What was your antiplatelet, anticoagulation strategy in this case?
Yeah, so we routinely use ticagrelor actually through the front door. So this patient had ticagrelor. And actually at that point, although there was thrombus, we haven't then used a glycoprotein 2B3 antagonist, just simply platelet therapy and heparin.
Great, thanks a lot. Javier, any final comments or
message? While I was seeing the case, I was again impressed on how all these contributed to the safety of the procedure. Just to give an example, I mean, this very nice maneuver of anchoring in the distal stent to negotiate the wire, the balloon to the circumflex. Tom could do that because he knew that the wire was going through the right cell. You will not do that if you have the suspicion that your wire could be behind the stent, for example. But he knew that, he could overcome this small resistance by using this maneuver. So congratulations. I think it's a great, great case and illustrates, again, the control that this imaging during PCI gives to the operator.
Fantastic. I would like to really thank you both for fantastic presentations, and I learned a lot. And I would like to invite you to continue discussion and try to answer questions on Twitter. Can I have the last slides? So this was very important webinar because we really discussed in real life using case examples and the best available evidence from the literature how to optimize treatment of left main disease using intracoronary guidance. And we can say that physiology-guided decision-making can help selecting adequate treatment strategy for left main patients. Then, when physiological assessment is performed, the influence of a downstream stenosis in LAD or circ should always be considered. IFR co-registration with angiogram can be helpful to discriminate the influence of downstream stenosis. And after main vessel stenting, FFR in the side branch is feasible and more accurate than angiographic assessment of side branch severity. Next slide. Intracoronary imaging, on the other side, facilitates technical planning and optimization of procedural result. Image guidance is strongly recommended whenever we expect difficulties and in order to achieve the optimal result. IVUS is the gold standard for left main PCI, and OCT is feasible for distal left main locations. OCT combined with angio co-registration and real-time analysis software provides real advantages for stepwise bifurcation strategy, especially 3D reconstruction to facilitate, as we saw, guide wire recrossing. I would like to take this opportunity to thank the faculty, but also to thank all of you for participating in this webinar and for putting your interesting questions, which helped us understand the needs. And I try to have the continuation of this discussion on Twitter, if possible, in order to get more knowledge and to exchange our practice and our experience and skills. I would like also to thank Medtronic for organizing these important webinars on PCR in bifurcated and left main lesions. And I would like to invite you to attend also our last webinar, which will be in March month. Thank you so much, and I hope to see you soon on Twitter, even today. Thank you and have a good day. Bye-bye.
Bye.